I have a blank screen. Does everybody else have a blank screen? I can't see anything. Apologies, folks.
It's the same on my screen as well.
You should be. You are live according to our side, Di, but
Okay.
Sure.
This could be
turn your camera on and
then.
off again. Jai, try turn your camera on and off again. It worked for me.
Right. Yes, good morning, everybody, and welcome to this Board of Directors for Lincolnshire Partnership Foundation Trust. My name's Di Bailey and I'm the Deputy Chair. Apologies for the slightly delayed start. We've had a few technical issues this morning and I'm not sure whether those technical issues are going to stay with us for a little while. So we hope not, but we will do our best in the event that they do. So without further ado, then into the agenda. I'm assuming that apologies for absence will have been noted. Does anybody need to make me aware of any declarations of interest other than those recorded in the documents? Okay, I'm not seeing anything. So just before we go into the minutes of the Board of Directors meeting held on the 5th of June, just to remind colleagues, if you do wish to make a contribution and speak, can you please introduce yourselves for members of the public who may not know us and may be watching and observing, and please refrain from putting comments of any significance in the chat. This is a public meeting and as such we should make sure that all contributions are recorded appropriately. So thank you for your compliance with that. So minutes of the meeting on the 5th of June. Are there any issues that anybody wants to raise with that meeting, or can we accept them as a true record? Okay, I'm not seeing anything. Can colleagues indicate in the chat if they are happy to accept them? Yep. Thank you. So on to the schedule of actions then and follow-up. I think these are fairly self-explanatory and they have been updated. So again, anything that anybody wants to raise with any of the actions, these are here for information. Okay. So that takes us to item 1.5 then, which is down as Chair's remarks, and just a few things that I wanted to say really by way of context setting before we get further into the meeting. So if anybody is observing this meeting who's observed previously, you will know that we typically start the Board of Directors meeting with a board story that is either from one of our people who use our service as a carer or from members of our staff. We did have that planned in for today. However, the person who was going to come and talk to us, who is somebody with lived experience of our services, has had to withdraw at short notice. And rather than try and fit something in, we decided to leave it and go with the agenda as planned. There will be an opportunity for that individual to join us at a later stage to fit with their commitments. I just wanted to remind colleagues as well that because of some of the external drivers that we're dealing with at the moment around changes to the NHS England, the ICB integrated care boards and other things happening within the context of the NHS as a whole, we are operating at the moment within what we're calling proportionate governance. So what that means is that some of our committees are meeting slightly less regularly, but dealing with issues as needed appropriately by circulation to the committee for decisions by email, etc. So, for example, in the agenda, you won't see that there is a substantive item around people today. However, there are a number of other items on the agenda where people will absolutely feature front and centre to our conversations. So, for instance, safer staffing reports from the quality side, and an update around some of our people workforce metrics in performance committee. So it is there, but it just reflects some of our proportionate governance in terms of those committees that may not have met since the last board of directors. That doesn't mean we aren't on it and we aren't dealing with the business as necessary. We're just using time efficiently and effectively whilst some of the external churn is happening, really. And then finally, I think I wanted to just make colleagues aware, if you're not already, that we do have quite a tight agenda today. We've got a number of reports, annual reports. It's that time of year, really, when things are coming to board for final sign-off. And it would be extremely helpful for those colleagues whose names are against these items as leads, if you could just emphasise for us what it is you're asking board to do. So, for example, for some of the reports, they've already been through scrutiny at other committees. The reason that they are here is because we need board sign-off in order to publicise them on the website, for example. So I think just making it clear why they are here for decision would help in terms of process, really. Again, for any of our public members joining us to make sense of why we're doing it the way we're doing it. Kevin hasn't made me aware of anything that he wants me to raise under Chair's remarks, so I will stop there and happy to take any questions if there are any. I assume that's fairly self-explanatory. So Sarah, over to you then for the Chief Executive's report.
Thank you very much, Di. Good morning, everybody. I'm Sarah Connery. I'm Chief Executive here at Lincolnshire Partnership, NHS Foundation Trust, and this is my usual Chief Executive report. As Di said, there's a lot of change and churn going on through all levels of the NHS at present. So a big thank you to colleagues through all of that change and churn. Continuing to deliver high quality care to our patients within our means as much as they possibly can. So a big thank you from me, particularly as we've just gone through another period of industrial action, and we wait with anticipation in terms of what the future holds in terms of future industrial action. But a big thank you to all colleagues who stepped up the plate to make sure that services could continue operating effectively during that period. We were expecting our National Oversight Framework scores to be published before this board, but there has been a delay to that. So that will be coming in September. So that isn't included in the report today. And latterly, we've been made aware that to accompany the National Oversight Framework scores, there will be a capability assessment. So that's something that will be taking the board through, because it does start off as a self-assessment, very much in line with all the other conversations that we're currently having about well-led assessments, for example, and insightful board. Just a few areas to draw your attention to today. Apologies for the length of the common board paper that we've got in terms of our East Midlands Alliance, our Mental Health Alliance, because not only does this paper talk about updates for each of the specialised mental health provider collaboratives that we've got, it also talks about all of the other areas that we're working on together around staff experience, around our data, around patient safety, etc. So I hope you find the report of use and interest in terms of the breadth and depth that we're working in partnership around the East Midlands on, which puts us in good stead for the future integrated care board clustering with Derbyshire and Nottinghamshire. I do also just want to point out our forward plan is included for 25-26, so welcome any feedback if anybody feels that there's anything missing from that report. Again, there is quite a lot in there. And just to note for board colleagues, the learning event on October the 3rd, so hopefully you've had the invite. Please do keep your eyes out for that, because we'll be doing something I'm really looking forward to, an update on our open dialogue pilot. We put ourselves forward to be the pilot for the East Midlands Alliance, so I'm really looking forward to hearing the learning from that. That's something that we've talked about at a prior board. Just a bit to end really on some celebrating success and good news story. Our national, the National Lived Experience Awards are coming up, and our patient partners are finalists in 4 of those categories, which is really great. And we've now announced our Every Voice People Awards finalists as well. So very much looking forward to the ceremony that again is coming up. And we're just about to launch our staff award nominations. So they'll be opening up next week. So that's something really that we look forward to. So I'll stop there, Di, conscious that there's a lot of papers to get through today, but happy to take any comments or questions. Thank you.
Thanks, Sarah. Just while I wait and check whether there's anything in the chat, I can see something from Tim. There were just a couple of points I just wanted to ask you about. One was in terms of the patient engagement portal, which you refer to in your report. I just wondered whether you could say anything more about whether that will move us towards a kind of one system of information to help with communication rather than the several that we seem to have at the moment. That was one point. And the other thing, which is probably more of an administrative issue, but I did think the Alliance report I thought was really interesting, and I think there are some real opportunities there for non-execs as well as colleagues. And I just wondered whether there was a way that we could get those flagged a bit more so that we know that they're happening and we can attend if interested.
Yeah, thank you. So if I pick up the patient portal first, it will be a sort of a window for our patients to engage with the trust. So sitting behind that, there will still be a number of software applications that we're using, but from a patient experience engagement with the trust, it's a sort of one window in, which is completely in line with the 10-year plan. So we're currently going through sort of a really wide engagement piece on that, because we want to make sure that we're getting it right. Really positive that we were already on that track. So the 10-year plan just kind of puts a thumbs up to it. But in terms of administrative time for our staff and in terms of patient experience, in terms of making appointments, seeing their records, something really important for us is patients being able to complete, outcomes paperwork as well, that we all do through our apps every single day. So it should make things a lot more efficient, but we'll keep you appraised. I'm certainly very excited about it. So something I'll come back to in the Chief Exec's report. And a really good point, I think, about the East Midlands Alliance. Sometimes it's only when I read the Common Board paper, I think, wow, there is so much going on. Yeah. That's why I really would encourage attendance at the October the 3rd event, because I think that's a window in to say, we'll be talking about the annual plan and how do we want to engage wider boards in that. So hopefully it'll be a really good day.
Great. Thanks, Sarah. Let me bring in Tim.
Thanks, Di. So Tim Harry, non-exec director. Just picking on that last point, I thoroughly would endorse going to that event. The last one was brilliant. So really good to go. The quick question really was around, actually in the first section, around the CEO meeting for the Midlands and East Mental Health. And it was around Aaron Chopra's vision around CQC inspections. I wondered if you could just give us a quick essence of what that vision is.
Okay, so I think it's fair to say that there's a lot of work for Aaron and his team to do in terms of making sure that our CQC processes are fit for purpose, and making sure that the experience of providers when they are under assessment, the focus is on continuous quality improvement and learning. So it was very much a two-way conversation, really, but the thrust of it is wanting to go back to relationship managers, because that was diluted under the previous arrangements where, to really get under the skin of an organisation, that relationship management is really important. Making sure that the IT infrastructure is fit for purpose as well, because there's been a lot of teething problems in terms of speed of reports coming out. So it's often been the case where when reports land, we've already completed the action plans almost. So making sure that we're sort of attending to those urgent needs and working on the action plan and having the reports in a speedy way. we had a really good conversation about making sure we're sharing the information, because we feed a lot of information into the Care Quality Commission, but sometimes we're not getting anything back in terms of, well, how do we fare? How do we benchmark? What's the insight from all of that data that we're putting in? So we had a good conversation about how that comes back out to us again, so that we can use it for our learning and improvement. And the final bit was around the using the excellent knowledge and learning that we already have in the NHS to be part of the future assessments through well-led reviews, so for example. So myself, Mark and Chris have signed up to be well-led assessors as part of the sort of executive team, special advisors. And I think that's a great way, you know, regardless of whether you're inadequate or good or outstanding or requires improvement, there's always things that people can learn, and there's always things that people can share. So more to come on that, but very much engaged. Aaron's going to come to our next relationship meeting. So that's another opportunity where we can keep that conversation moving forward. So hope that answers your question, Tim.
Yeah, no, great. Thanks, Sarah.
Thanks, Tim. Mark, I think you had a comment on the patient portal.
Yeah, brilliant. Thanks, Di. So good morning, everyone. Mark Platts, I'm the Chief Finance Officer, but also the Executive Lead for Digital, so supporting the team on the engagement around the patient portal. Sarah's picked up on a lot of it. I just wanted to kind of make a link into the multiple systems bit. So we have a plan around how we're going to bring all of our systems together, but ultimately for the public and our patients, it's going to be one entrance through the NHS app that a lot of us downloaded during COVID times. It will look familiar. It will feel exactly the same as the app operates now. It will just have your mental health data in there that we're providing through the trust. So really important point in there. Bit of a plug, if I could, conscious we're on public board, there is a link to a survey on our website. So public patients can click on that survey and actually help start to support the development of the portal and move it forward. And we're also going to set up a patient reference group as well as we get deeper into the project. So keep a lookout for that. We're starting to talk about it now because we've got the funding through and we're starting the engagement. But certainly as the project kicks off, we'll bring a lot more through to the public so we can maximise engagement.
Thanks, Mark. That's really helpful. Ian, you want to come in?
Yeah, thank you. Morning, Ian Orrell, Non-Exec Director. Yeah, just gone back to Sarah's report. Thanks for the report, Sarah. Just wondered if you could say a little bit more about the neighbourhood health pilot application.
Yep, certainly. So I can confirm that we have submitted. So this came out shortly after the release of the 10-year plan. It's very much a bid led by the Integrated Care Board, co-signed off by our from Lincolnshire County Council as well. So it was asking for local authority approval, as well as if there's a combined mayoral authority, for the mayor to give approval as well. So it was quite a tight turnaround in terms of being able to put in the bid. And it was quite a tight word count as well. So it was a very involved piece of work to make sure we could get all the signatures that we needed and keeps the word count, and really distill what we want to achieve here in Lincolnshire as a place. So the bid is very much as Lincolnshire as a place. What I was really pleased to see was lots of reference to our community mental health transformation as a real solid building block to move forward around sort of physical and mental health integration moving forward, building on some of our community assets that we've already got. Our How Are You website, for example, where people can access lots of community assets, walking groups to reduce social isolation, etc. So we wait with bated breath to see if we've got through as one of the pilots. But yeah, I think it was a strong bid and fully supported by all of our Primary Care Network Alliance clinical directors, which again is something really positive.
Thank you.
Thanks, Ian. Okay, I can't see any other questions or comments, Sarah, so thank you for that. Really comprehensive as always. I think the next one is also yours, the Freedom to Speak Up annual report.
Thank you, Di. Yes, with pleasure that I'm presenting this report today. As you've mentioned, in terms of the governance, this report has already gone through the Audit and Risk Committee, and I believe was positively received. I do like to think this is our window into what one of our values is: our voice and actions matter. And I think this is a real chance to sort of check and balance to see whether that is actually the case here at LPFT. We have had an increase again in terms of people speaking up, which we've always talked about here at the board as a positive, particularly because we're hearing more from people with protected characteristics. And I'd like to think that is a real reflection on how we've built our champions network for freedom to speak up, and making sure that we've got representation in our staff networks, so that people have got that direct sort of connection through to people with protected characteristics. Really pleased to see the learning section, which I think really tells a story in terms of how we don't just listen, but we act in terms of what we're hearing. And also some great feedback for Stu in terms of his personal approach as well. And I have the pleasure of line managing Stu with his very tricky job, which is, you know, very complex, but he approaches it with compassion and real great insight. So a big thank you for Stu for all he does through the year, as well as our Freedom to Speak Up champions who are making such a big difference. It does note in the report that Penny Dash's report on the sort of patient safety framework going forward, there was a recommendation that the National Guardian's Office is sort of stepped down. But I don't think that, you know, there's nothing in that would suggest that we don't continue to push freedom to speak up, something that we're really committed to as an organisation. And just to point out as well in the report that we have now got our Every Voice Guardian to make sure that we're elevating the patient voice as well as the staff voice. And as evidenced through our National Lived Experience Awards, you know, that is having a real positive impact as well. But as always, more to do. As I say, it has already been through Audit and Risk Committee, so this is presented just for information today.
Thanks, Sarah. Thank you. And I was actually at the Audit and Risk Committee, so we did give it a very thorough going over and noted, as you say, really very commendable in terms of the work that's been done. So, yeah, thanks for that. I'm not seeing anybody with any comments or queries, so I think you are released. Have safe onward travel and enjoy.
Thank you very much, Di. Thank you, colleagues. Thank you.
Okay, Karen, we're with you now for the board assurance framework, and I think this does require a decision on behalf of board.
Thank you, Di. Yes, it does. I'm Karen Scott. I'm the Trust Secretary, and I'm really pleased to present the board assurance framework to the board today in slightly different guise. As alluded to in previous board meetings, we undertook a comprehensive review of the board assurance framework during Q1, and as is set out in the report, which I hope is fairly clear, each of the respective board committees that have responsibility and oversight of the respective sections within the BAF have actually reviewed that during Q1 following the proposed changes that we made to it. There is a summary of those things that have been amended or introduced or refined, so I won't go over those specifically, but really just to highlight that it has undergone thorough scrutiny, even under proportionate governance arrangements, in the absence of a people committee meeting during Q1. Committee members have had an opportunity to virtually review that, and the revised version did go in the full version that was reviewed by the Audit and Risk Committee. It was agreed at that stage that would be some further iteration to reflect some further emerging actions that were necessary following some CQC findings. And that is the first time that these have been identified on the iteration that's presented to the board today. Other than that, Di, I don't think there's anything I specifically want to draw out. I hope that board members find it more straightforward read. We've even introduced some sort of context at the outset of the document for members of the public that might, and colleagues and other members of staff within the organisation, that might help provide some of that additional detail regarding what the board assurance framework does, and the reason for it being. So happy to take any questions or comments, Di, or defer to colleagues for any specific questions in relation to sections of the board assurance framework. Thank you.
Thanks, Karen. Comment from Tim. And
yeah,
Tim?
thank you, Di. So Tim Harry, non-executive director. Just to commend Karen and her team on all the work that's been done on the BAF. I think it is much more sort of approachable and sort of usable. But I think we now are at a position where we can really use this as our baseline, and I think that's really what we've got to do sort of moving forward. I know there'll be further developments, but I think it's in a position where we can really get some really good value out of it. Thank you.
Thanks for that, Tim. And I think certainly that would echo comments that I heard about it in Audit and Risk Committee and Performance Committee. Ian, did you want to come in?
Thank you, Di. Yeah, Tim's stolen the first bit I wanted to say, which was just to commend the work that's been done. I think this is putting us in a lot stronger place, whilst recognising, and I think everyone does, that there's always more to do, and so on as we go forward. I was just wanted to make one particular point. I was particularly pleased to see that we've updated for the recent CQC issues. But I also just wanted to say that in our first line of defence for a lot of the quality areas, we've also got a reference to mock CQCs being done, which I think is a positive thing. My question, and it's probably not for now, but perhaps someone can update me later, is really to get, for me personally, a better understanding of those mock CQCs, what their brief is, what we've found through those particular assessments, how we're reporting those findings, etc. So there's a bit of me that is really pointing at how we improve the BAF as a whole. So that's just a final comment. As I say, I'm not sure it's appropriate for someone to respond to all that detail at the moment.
Thanks, Ian. I thought I saw Sharon respond, but did I?
I can't see that on my screen. Oh, you
Yes, sorry,
I did.
Sorry, Sharon. Yes, I did, didn't I? I'm not dreaming.
No, you're not dreaming, Di. Sharon Harvey, Chief Nursing Officer. So, Ian, I will send a summary separately to hopefully answer the questions. But just for all board members' awareness, we do a range of different types of mock visits. So we do mock Mental Health Act CQC visits, which should replicate what the CQC would look at when they do a Mental Health Act monitoring visit. And we do have other types of mock CQC visits, which we're trying to bring together within our 15 steps visits. And myself and Eve Baird, the Chief Operating Officer, are talking about how we can engage more of our quality leaders across the organisation in being involved in peer reviewing, so that it doesn't just sit with our CQC compliance team, but that we skill up our staff by doing, and they go and understand each other's visits and then take the learning back to their own areas. But it's a work in progress. It's something that we've just started looking at in terms of that peer review. But I'm happy to send a summary of what the visits look like, how they play out across the organisation outside of this.
Really helpful. Thanks.
Thanks, Sharon. That's really helpful. Karen, I thought I saw your hand go up as well at one point. I wasn't sure whether that was in response to the comments by Tim.
No, apologies, Di, it was in error. I was clicking on the wrong button, so apologies.
Right, okay. Okay, let me just see. Right, I think we're okay then. I can't see anything else, Karen, so I think we're happy to agree the board assurance framework. Can people just indicate a yes in the chat if you are? Yes.
Thank you, Di.
Good. Thank you. Okay, so we're moving then into the outstanding quality part of the agenda, and Sarah Whiteman with you for the report on the last quality committee meeting.
Good morning, Sarah Whiteman, Non-Executive Director and Chair of the Quality Committee. The last report was on the 17th, this last meeting, sorry, was on the 17th of July. Three things I really wanted to draw people's attention to, and two other items that we'll be keeping an eye on moving forward. Response to CQC inspection, excuse me, and the governance review that was instigated as a result of that, highlighted issues with data reporting, assurance mechanisms and reporting routes, escalation triggers, and training and education challenges. And to that effect, a working group has been set up to bring a project initiation document to the next quality committee this month. So that's happening. Two other concerns around physical restraint and the trust being an outlier for that. We feel that probably relates to a very low threshold for reporting, but it's something that we need to clarify because we don't want to be an outlier. And if we're recording data, we want it to be meaningful so that we can act appropriately on it. So that's another area that we're scrutinising. And then the issue of care planning, which is also reflected in the responses to the National Community Mental Health Survey. Because of the CQC issues, we didn't consider at the last quality meeting the clinical effectiveness review, which we're very keen to focus on. So that's a test of how we know that what we're doing is for the benefit of our patients. So the Chief Medical Officer has been tasked to give us a succinct précis so that we know that we're doing the right things in the right way. And also the Suicide Prevention Action Plan is something else that we'll be looking at our next meeting. Thank you, Chair.
Thanks, Sarah. Any questions or comments? Sarah, can I just check then, because I'm aware that we've got the suicide prevention strategy priorities on the agenda, which we're coming to in a minute. So has that already been through quality committee? Yeah.
It has, and we recommended some amendments which have been incorporated.
Right, okay, that's helpful. Thank you. I just wanted to check. Brilliant. Okay, I'm not seeing anything, although we do continue to have some IT issues, folks. So apologies if I am missing anybody, but I don't think so. So thank you, Sarah. So Sharon, I think we are then with you for the next 3 or 4 items on the agenda, which relate to some of the items that Sarah has highlighted already from Quality Committee.
Thank you, Chair. Sharon Harvey, Chief Nursing Officer. So the first item I'm going to talk the board through is the Community Mental Health Survey results from 2024. As Sarah Whiteman identified, we discussed and presented these results at Quality Committee on 2 occasions. In April's Quality Committee, we had early sight of the findings and the results, so we gave a high-level update before we'd had a chance to analyse, and then a full paper went in July. But I'll just quickly talk board through the key points and findings from the questionnaires. So the questionnaires that were sent out had a major redevelopment ahead of the 2023 survey. So we're only able to compare the results that we've got for 24 to 23. So we can't do a longer term comparison on many of the questions. And just to remind colleagues that the survey is for people aged 16 and over. So it's not just adults, it's 16 plus. We have an improved response rate for LPFT this year, which I'm really pleased with. We've made a concerted effort to do that. So 24% is our response rate this year, and that's compared to the national average of 20%. And we had a 21% last year. So it is an increase in terms of the response rate. The key things that we've found through the results there's some challenges around the demographics of the survey and areas being underreported from protected characteristics compared to the population that use our services. And overall, we did not score above the national average in any area. However, we were about the same as other trusts for 29 questions, and the report details exactly where we were, which questions. The bits to draw attention to, because they triangulate with our other findings and learning, is, as Sarah had said, around care planning and around making sure people have had a care review and having a care plan, which we know from other areas, including recent visits, but our own audits tell us that whilst people have care plans, it might not always feel meaningful to the person that has them, and we don't assure against them in a strong enough way around the quality and the personalisation of the care plan. So there's more for us to do around that. And you'll see through the Quality Committee Highlight Exception report that I've called a care planning summit to bring together a range of people from point of care, including people with a lived experience, up to board, around really understanding we've got lots of action plans in place. Are they high impact enough? What are we going to do? So we are really having a targeted focus around that. One of the requests from Quality Committee was that we seek out learning from other organisations and try and see how they've managed improvements around the survey. And you'll see the paper talks about where we've done that and where else we're going to link in with. We've had a detailed discussion with Navigo. They consistently perform very highly in this area. So we've had adopted some learning from there. Whilst the results aren't what we'd necessarily want to see, I do want to make sure that colleagues realise that we have improved in 5 areas. In one of the areas we've significantly improved, which is in the area of have the mental health team asked if you need support to access care and treatment. So that's really positive, but of course there is much more to do. Last year, board were keen to triangulate with other bits of feedback to make sure that we take seriously what the Community Mental Health Survey says, but don't see it in isolation from our other areas of assurance and feedback. The paper identifies we've done that to some degree, especially around the access and weights and looking at where we've got concerns and issues through our complaints themes. But I do think there's more that we can do, and I'll be scrutinising the action plans in place to try and make sure that we bring that together across a whole range of different areas of feedback. But we've also recently set up our continuous quality improvement and triangulation of learning forum, which will enable that much more clearly as well. We've done a thematic review of the narrative responses, which I think is really helpful, and we've noted from that that there are similar feedbacks to other sources of feedback, such as our friends and family tests and the themes of the formal complaints, and that's around the communication and around access and weights. The final thing that I just want to draw board's attention to is, whilst we have got improvement plans in place for each of the divisions, and we did that last year and we've seen improvements in some of the key areas, the collection for the current survey is already underway. So the improvement plans we're putting in place now, we would almost see a little bit further down the line. Yes, happy to take any comments and questions, but as I said, this has already been through Quality Committee as well.
Yeah.
Thank you.
Yeah, thanks, Sharon. And I think just a couple of comments from me as Chair of Performance Committee. We look at the Community Mental Health Survey results as one of the measures in the performance dashboard that we look at. And I think it was interesting. So there was certainly no surprises for me around the care planning and the support while waiting, because I think from a performance perspective, we know that we've got some issues in that area. So I think in a way it's good evidence that we are the same things are coming up in different places, which I think gives us confidence that we know where to shine a light. And I think the idea of the summit is absolutely the right idea in terms of looking at this holistically rather than in the different sort of silos that we might otherwise fall into. So those are just comments from my perspective. Anything that anybody else wants to ask or comment on? No. Okay, so I think it's the safeguarding. So sorry, Sharon, can I just be clear, because this is here for decision and
the safeguarding report.
I've got community patient survey results is here for decision. I'm assuming it's just for board to sign off. Or
yes, I think it is just to sign off. There isn't an actual decision to be made. I think it's for information.
Yeah. Okay. Thanks. Yeah. Okay. Right. Okay. And I think Chris is just telling me that he's happy to agree it, if we have to agree it anyway. But I think we don't. It was an error on the agenda. Right. Safeguarding annual report, which is here for information. It says.
So this is here for decision. I apologise. Right. I'm not sure what's happened with the with the agenda if it says so. Sharon Harvey, Chief Nursing Officer, in case anyone's just joined. The Safeguarding Public Protection and Mental Capacity annual report is here for decision. So the decision we're asking the Board of Directors to make is to approve this going onto the website and assurance that this is the annual report and plan. So it's my responsibility as the Chief Nursing Officer to present this report to the Board of Directors as the Safeguarding Executive Lead, and NHS trusts are required to publish an annual safeguarding report. So that's what this is. The report's already been discussed and approved at our legislative group and at the Quality Committee, and both groups are making the recommendation to approve by the Board of Directors today. A couple of bits I just want to draw attention to prior to making the decision is the report takes into account the national safeguarding context, including things like the implementation of Right Care, Right Person and the enhanced multi-agency cooperation that comes with that. Locally, we've strengthened our safeguarding systems in the last year in response to increasing complexity, emerging risks such as online exploitation, and the recognition of children as victims of domestic abuse. Against all of this, our safeguarding teams delivered a high level of support, leadership and oversight. And this year, they've responded to nearly 20,000 requests for advice. The figures, I think, are testament to the critical role that safeguarding plays on a daily practice in our organisation and the Trust's commitment to safeguarding. In addition, I'm really proud to see that our Safeguarding Champion Network continues to develop, and it's critical to our work that we do that. So I present this to the board for decision to approve. Thank you.
Chris Wright.
Thank you, Di. Chris Wright, Non-Executive Director. Thanks, Sharon. This is very relevant because Girish, Chief Medical Officer, and I, on Tuesday, I think it was, we went to visit the Safeguarding and Mental Capacity team and came away very impressed by the quality of the team and the intelligence, the way they go about the work, and it's incredibly challenging and demanding, and they're providing a high level of assurance and support to our colleagues, and we should be really grateful for that. The substantive point, I guess, is related also to the work stream you're leading around releasing time for care, and just the plethora of different risk assessments and tools that we're using. We specifically talked about the various DASH tools and just the need for harmonization. And I appreciate it's not simple or easy, and there'll be a range of trade-offs, but just to highlight perhaps the urgency of trying to reduce some of the demand so that we can end up with a more streamlined approach to managing risk.
Thanks, Chris. Sharon, do you want to come back on that?
Yeah, absolutely. And just for colleagues, the DASH assessment is the domestic abuse, stalking and harassment screening tool that the safeguarding team use. And yeah, absolutely, the safeguarding team will be part of the releasing time to care task and finish to make sure that we're considering all areas. Some tools are prescriptive to us, especially around domestic abuse. There are some tools that we absolutely have to use and that are multi-agency, but the wide range of risk assessment tools we use and how we make it easier for our clinicians to get the right information, to not have to repeat the information in lots and lots of different ways, and for people that use the services not to have to repeat is really central to the release and time to care. And one of the bits the safeguarding team have done, they probably told you about it, Chris, but they've developed a safeguarding hub to try and make sure that they can get the responses back to clinicians quicker, that they can triage things more effectively and quicker, and cut down the amount of touch points that clinicians have to have when they seek support and advice. It's probably one we should try and actually capture through release in time to care, because it has freed up some capacity and got the team working smarter.
Thank you. Absolutely, the safeguarding hub, it seems to be working very well. Absolutely, yeah. Thank you.
Thanks, Chris. Thanks, Sharon. Can I just check, Sarah Whiteman, was that a question or a comment you wanted to make?
No, it was just about the decision to approve the safeguarding
Okay,
report.
that's fine. Thanks, Sarah. I just wanted to check. Right, I think we're okay then, Sharon, for that. So I think we're happy to approve this, and then it will go on the, as you say, it'll go on the Trust website. So yeah, thank you. So we stay with you then for infection prevention and control, the board assurance framework and the annual report.
Yes, so the annual report is here for decision, and the BAF is here for information. But I will take an action to double check for any future papers that come that we've ticked the right box on all of these, because I can see a theme occurring. So apologies, colleagues. So the IPC annual report, this is here to provide the Board of Directors with assurance that we have met our statutory requirements in relation to the Health and Social Care Act and the Code of Practice. So the key highlights from the report is that we haven't had any incidents of healthcare acquired infections through the year, and throughout 24-25 there's been low levels of COVID or other respiratory virus outbreaks. We've had 29 reported COVID-19 outbreaks, but of course please bear in mind that the testing requirements change, so it's hard to have an accurate picture of that. This is higher than the same reporting period for 23-24, but it's lower than the local, regional, national providers. Level of compliance with the IPC board assurance framework are provided quarterly to the Quality Committee via the IPC group throughout the year, and so the Quality Committee has regular oversight of those, and we've seen compliance increase through the year. The key achievements of the IPC team include, and I'm really proud of the team for this, and the departments across the organisation, when we, at the time of writing this report, were at 92%, nearly 93% compliance rate for IPC training, and that's been a lot of tireless work, including, I need to do a shout out to the medical directorate, because usually we struggle to get their compliance to where we need it to be, and thanks to the push from the Chief Medical Officer, we're doing really well in that area. Our priorities for the year ahead, we need to increase the uptake of the flu vaccines and look at how we do our flu programmes. We didn't get the uptake we would have liked this year. We weren't alone in that. I think there's been a challenge and some fatigue nationally around vaccines, but we really want to push on that. And we're looking at how we can implement the fit testing strategy, because you'll see that's the only area of non-compliance on the BAF. And I don't think there's anything else I need to draw attention to, but I'm happy to take any questions and comments before the board make a decision to approve the annual report. Thank you.
Okay, thanks, Sharon. I'm not seeing anything, so and I've got some yeses in the chat, so yes, we are happy to approve.
Thank you. Are you happy I move on to the IPC BAF, Di?
Yes, yeah, absolutely.
Okay, so the IPC board assurance framework is here for information and to provide assurance to the board of directors. It's a national board assurance framework which is issued by NHS England, and we have quarterly oversight of this through the IPC group and also through Quality Committee. Overall compliance since the last quarter has shown that we're now compliant in 40 out of the 42 areas. There's one area that we're not compliant, which is the fit testing I just spoke about a moment ago. 2 areas of partial compliant, and 1 isn't applicable to us as an organisation. This is an improvement from 48 domains being compliant at the end of 24-25. So you'll see from the annual report that the areas for improvement are the areas that we're focusing on and improving across the coming year. And the only area that we are unlikely to achieve full compliance is around the fit testing, but we have got mitigations in place, oversight through the health and safety group, and there's an improvement plan in place, but we think it's unlikely we'll meet full compliance on that. So I just want to express thanks to the infection prevention control team, and this is here for information. Happy to take any comments.
Okay. Again, I'm not seeing anything, Sharon, so I think we're happy with that. It makes sense in the light of the annual report, really, in terms of what you've said. We know is on our radar. Okay, so last one for you, safer staffing establishment review.
Yeah, so in case anybody's just joined, Sharon Harvey, Chief Nursing Officer, and presenting for decision the Safe Staffing Establishment Review to Board of Directors. So it's my responsibility as the Chief Nurse to present an establishment review twice a year to the board. And the purpose of the reports to summarise the findings of the establishment review, its recommendations, and to assure the board that we've undertaken the review in line with National Quality Board guidance and the NHS Improvement Guidance from 2018 around safeguards. So the establishment review and the confirm and challenge panel, because colleagues will remember we've established an additional layer of governance around our establishment review, which is a confirm and challenge panel. We've also, since the last review that the board had oversight of, we've trained some of our patient partners, so people with a lived experience of mental health conditions still using our services, in safe staffing, so that they can be part of the confirm and challenge, so that we've got that real what it's like on the wards. And to have that debate and discussion in there. And I just want to give the assurance that they've been properly trained by our safe staffing team to be able to do that, to have meaningful engagement in the panel. The committee, this went through quality committee, and quality committee were pleased to note the lived experience representation, and overall, we are not recommending any changes to the staffing establishment. We have, however, made some recommendations in relation to the use of the rostering templates for Ward 12, which is our acute ward over in Boston, and Langworth Ward, our older adults ward, and Maple Lodge, our rehab ward over in Boston, to make sure they're efficiently deploying staff within and making best use of the resources. So just to confirm that I'm assured the due process has been followed. This is here for decision for the Board of Directors, but we're not making any recommendations for changes to the inpatient establishment. Thank you.
Thanks, Sharon. That was really clear. The paper was really clear, I think. I'll just while comments put in the chat that they're happy to approve. The involvement of patient partners with lived experience, to what extent is that common in these kind of establishment reviews across similar trusts? Do we know?
I don't believe it is common. When Sarah, Mark and I joined, so Chief Executive, Chief Finance Officer and I joined one of the regional calls, and we made reference to that, and that no one else had done that or heard of it. So I think we might be one of the first to do it. The feedback from the patients involved, and one of them's one of our staff governors, patient governors, felt that they were really meaningfully involved, and the safe staffing lead felt that they put in appropriate challenge, really good questions, were really well prepared. So yeah, so I'm really proud of it.
Yeah, no, quite rightly so. Thank you. And I think it fits with our values, doesn't it, around inclusivity and making sure that people are heard. Yeah. Okay. Yes. Okay. So we're in agreement that you've got the decision. So I think you're released now. You can go and have a cup of tea, and we'll hand over to Girish for the suicide prevention strategy priorities.
Yeah. Good morning, everyone. And thank you, Di. I'm Dr. Girish Kunigiri. I'm the Chief Medical Officer for the Trust. Today, I'll be talking about the Suicide Prevention Action Plan. Chair, I need to just mention that as Dr. Sarah Whiteman, the non-executive director, was saying, this was discussed in the quality committee. And one of the things which was raised is to make clarity in terms of whether this is an action plan or the suicide priorities. So I've discussed with the team and made it clear that it is the action plan, what I am discussing here, and requesting the board to approve this. I mean, in terms of giving a brief background, I mean, we all acknowledge that every death by suicide is a loss of a loved ones, and suicide is generally multifaceted. However, the clinicians needs to be very much aware of it and do everything they can in a multidisciplinary team to prevent such kind of strategy. So the action plan, what is being presented, was co-developed, and it is in line with the recommendations from the National Suicide Strategy, which is a requirement across the country, which was released last year. And also following that, the ICB partners came together to have an ICB suicide prevention plan, which LPFT was very much a part of it. And then we did our own thematic review, which I'll be talking in next couple of minutes. And we had to put the recommendations from all these three into one single action plan, which is what is in front of you in the appendix. So as you can see that the action plan has mainly 18 actions, some of which have already been completed, and then the others are currently in progress. I want the board to note two key things which are very key, and some work is going on with some degree of challenge as well. One is in terms of the real-time surveillance. At the moment, the patient safety team spends a lot of time in terms of manually trawling through different sources of data to identify people who sadly die by suicide. And LPFT is working with other partners within the system, including the ICB, the police, the coroner, the EMAS, and the local authorities to see how we can make it more effective so that it benefits all partners as well. And that is why IT is quite important in this. The second was in terms of the safety planning. In the organization, we have taken the stance that currently under the leadership of Sharon, who is our Chief Nursing Officer, we are having a task and finish group on care planning and risk assessment, and safety planning will form very much part of it. And this will be considered under the L1 umbrella of releasing time to care. So that is something which we will be presenting to both the quality committee and to the board in coming months. The next part of the paper is to talk about the thematic 5-year review, what the trust has commissioned, which was in 2023-24. This was with the aim of ensuring that the number of deaths within our organization or who are known to our organization is in line with the national picture, and also what are the key themes, what we can learn. So as a result of the review, we had extensively reviewed 120 patients between the year 2018 and 2023. This is for those patients who sadly died while they were within our service or within 6 months of discharge from our service. And the paper talks about providing information on the demographic characteristics alongside highlighting that the prevalence of suicide is relatively more in people with comorbid conditions like substance use, physical health issues, sleep problems, and unemployment. The thematic review also highlighted issues related to data recording and also the comorbidity, which may influence this. I'm happy to share the detailed report if anyone is interested. The appendix talks about a brief video on the summary of these findings. Again, to assure the board that the trends what we have seen within the LPFT is in line with the national trends, and the recommendations from the thematic review are incorporated into the final action plan as well. So one of the key things with regard to the thematic review is, again, in terms of clinicians' awareness on suicide and how important it is to have this information in terms of making safety plan. And we have ensured that this theme is incorporated into the mandatory training for all the staff, who join our organization, and it is going on quite well. In terms of the governance, both the thematic review actions, which is now incorporated into one suicide action plan for the organization, is monitored through the mortality surveillance committee, and then it reports to the quality committee. In the paper, I have briefly mentioned about the trust requirement for national confidential inquiry. When I first joined about 3 years ago, there were significant issues with the backlogs, but I'm pleased that with the robust system what we have put in place, this has significantly reduced. So in conclusion, this is a paper for approving the suicide action plan, what we have collaborated in line with the ICB and the national strategy. Thank you, and happy to take any questions.
Thanks, Girish. That's really helpful. Just while I wait to see if anybody else has anything that they want to add, I had a couple of questions stroke comments. So the first was really about the timing. So this, if we approve this action plan today, which I'm assuming, you know, we will, it takes us to 2029. And I realise that obviously it's been, you know, it reflects the national framework and the Integrated Care Board ask, if you like. I just wondered whether we are, you know, given that it will continue beyond the life of the current trust strategy, whether there's anything that we need to do or be aware of in terms of the current trust strategy, given what we've now got in this action plan. So that was my first question, if you don't mind, please.
Yeah, thank you. I'm happy to respond to that. Like with any action plan, they are very iterative. And this is an action plan for our LPFT. Yes, nationally and locally, we need to align with some of the actions which are recommended by them. But at the same time, as an organization, based on our strategy and based on some of the learnings we have from the PSII reports, which is with regard to patient safety incidents, and also with regard to some of the SIs, we continually update our action plan to say whether it reflects, you know, what the current need is. And if we are making any changes with regard to our action plan, obviously that will come through the governance system to highlight the reasons for the change and for the approval before it is taken into implementation.
Okay. Thanks, Girish. So my other point really was just to pick up on the previous conversation that we had with Sharon around, you know, the sort of releasing time to care agenda and the risk assessments. And again, I'm just very mindful that in terms of those risk assessments that we do around people's safety, there often are multiple of those. Whether we need them all, I think, is a questioning point. And I guess it's in the light of this, whether we can look to consolidate some of that, really. But that's more of a comment than a question. Okay. I think people are happy to approve this. So I think that's fine. Yeah, thank you.
Thank you.
Okay. So I mentioned earlier that while we hadn't got anything substantive under outstanding people, we've made reference already to work that's been going on with the People Committee virtually. So I think then we're into the best use of resources part of the agenda. So Chris Wright, we're with you for the last report from the Best Use of Resources Committee, please.
Thank you, Di. And Chris Wright, Non-Executive Director, and I chair the Best Use of Resources Committee. Just context, we've also established a Living Within Our Means programme board, which is the board which now looks at the financial performance and financial plan. So the Best Use of Resources Committee is focusing largely on our other areas of oversight. The committee last met on July the 3rd as a formal part of its agenda, and we've subsequently had an extraordinary meeting last week, which we'll report on in a subsequent board meeting. The committee on July the 3rd met at Norton Lee, the construction site in Boston, where we're having our new inpatient wards built, which was a great experience, and it's brilliant to see all the hard work that's gone into that programme coming to fruition. And the programme, we should all be very proud of the programme and the progress that's being made, and how the wards are being developed very much in line with what best practices around such institutions. So it was a really good visit. The committee itself focused on a number of issues. We received a report on the new contracting and procurement arrangements we've put in place within the trust, and feel very confident we're building the right kind of capacity, which will place us in good stead for the future. As is the theme of this board meeting today, we received a number of annual reports, one on data security, which gave us again assurance around the rigour that's been applied across the trust to try and protect us as best we can. We also received a Calder Guardians report, which we'll hear of later on this agenda, and the Green Plan refresh. And just finally on the Green Plan refresh, just want to say the committee is really exercised to ensure that we remain focused on achieving our Green Plan ambitions despite the constraints of our new financial circumstances. So we don't want to lose sight of the importance of delivering on the Green Plan. And just an illustration in relation to that, Mark Platts and his team needs to take great credit for the work that's gone on at Discovery House and the installation of the solar panels there, which are having a very significant impact on reducing our heating bill. Anyway, that's probably enough for me on that, and open to any questions, or back to you, Di.
I'm not seeing 20 questions, Chris. So I think we're content. Sounds like you had a really productive meeting, actually. I still haven't seen Norton Lee, so that's a plea out there. If anybody's going, I wouldn't mind going and having a look. Okay, thank you. I think it's Mark then for the Senior Information Risk Owner Annual Report, otherwise known as the CIRO.
Yeah, brilliant. Thanks, Di. So good morning, everyone, again. So I'm Mark Platts. I'm the Chief Finance Officer, and I'm also the CIRO, which is the Senior Information Risk Owner. So presenting today the annual report that we present to board for approval and awareness, really, just to bring the board and public up to date around our progress around information safety and how LPFT is working from a cybersecurity viewpoint. So, as Chris has already mentioned, this report has been scrutinised in detail through the Best Use Resources Committee. So, I will just pick up on some of the key highlights as we go through. So, something I'm really proud of again as a team and as a trust, our data security protection toolkit assessment was completed this year. And it was a successful assessment with some low-level risks that were identified, but actually more importantly, there was some high confidence around the processes and procedures that we have in place to keep our data safe as an organisation. Where we don't quite get it right as an organisation, we do have data protection incidents that we have to report through to the Information Commissioner's Office. We had a couple of those this year, so again, it's good to see a low level on those. But more importantly for me, the office came back and they were happy with our resolution and our processes to deal with them. So some great work on that. Cyber security is one of the biggest things that as an organisation, member of public, individual and society, we need to be really aware of and kind of understanding the risks around it. So one thing that we have done this year is we've completed a cyber maturity audit as well as a digital maturity assessment. So both of those have come back with positive outcomes around our grip and control. So some really positive things there. But again, please, any member of the public, any member of the staff, please be careful when you see any text messages or emails with links or anything in. We've really got to be mindful around cyber security at the minute. In terms of moving forward, artificial intelligence is certainly a hot topic around at the minute. So as a trust, we are embracing the use of it. So we're working with Microsoft to fully utilize their Copilot function where we have licenses in the organization. So really seeing some benefits around how we can save time for our colleagues around analysing meetings and other functions within that as well moving forward. So there's going to be some great work as we move forward around that. But again, I have to say, as the CIRO for the trust, we have to do that safely, and that's really important as well. So just a couple of other bits as well. We reported our top risks on our risk register. As you can see on that, they're cyber related. So I'm going to close there, Di, and just sort of say, please be safe, everyone, when it comes to cyber security.
Thanks, Mark. Important message there, I think, for colleagues. So this is here for decision. Yeah. We happy? I think so. Yep. Yep, that's fine. Good. Thank you. So, Girish, we're back to you for the Caldicott annual report, please.
Yeah, thank you, Chair. I'm Dr. Girish Kunigiri, the Chief Medical Officer, and I'm presenting. I'm not sure whether it's for decision, it's more for information about the Caldicott Guardian, I think. Is it for? Yeah, it's the annual report, so it should be for decision. Sorry. Yeah. Before I start, I need to thank the author of the report, Dawn Sherlick, who is our data protection officer. She has been very brilliant, and she has been with us for many years with long experience in that. And the paper is here to assure the board that as a Caldicott Guardian, which is one of my portfolio, along with the data protection officer, we ensure that on confidentiality matters related to patients, families, and staff, we do it in an effective and safe manner. As a part of the Caldicott Guardian, it's important that when we are sharing personal information of any of the staff or the patients within our own organizations or with other organizations within the system or outside, we need to make sure that the shared information is lawful, ethical, proportionate, and confidential. And any breach may result in adverse outcomes both to the individuals and families, and may have an impact on the reputation of the organizations, and sometimes it may have financial penalties as well. So the paper talks about various elements in this role, including issues related to the breaches we had in the last 1 year, and some of the audits we have done internally and externally, and some of the data's we have received. I want to just highlight 3 or 4 key points with regard to this report. So one is with regard to the number of data subject access requests we receive as an organization. So every year it is more than 1,000 requests, in addition to all the good work what the data team does. All the data requests, particularly with the patients, needs to be approved by the clinicians, and it takes a lot of time for the clinicians to look and ensure that no third-party information is released, or if it is needed to be released, we seek the appropriate permissions, and it needs to be done within 30 days deadline. There is a challenge associated with that, particularly when we are having very complex cases involved with safeguarding and so on, and also having temporary staff in the organization, brings another challenge, because as they move, whoever is replacing them, they will have to trawl through all the records. The second point is with regard to accuracy of the records. We always encourage clinicians to write letters directly to the patients where possible, and then copy to the GPs. It's the same with regard to the care plans. Obviously, they are very much involved, so that in future, patients don't have to feel that some of the information what was recorded was not right. I think as we were discussing earlier with regard to the patient portal, I think there is a lot of push, nationally and locally, that patients are able to access their real-time data, particularly on the NHS app. And we need to see how we are able to comply with that, and also ensure that issues related to confidentiality is maintained. Last point was with regard to Caldicott decision log summary. This is where sometimes it can be very challenging with regard to particular individuals when they are requesting for certain information, or an organization is requesting for some information. We have a robust process in terms of having multi-professionals meeting, and I also have the liberty of contacting our peer Caldicott Guardians, and also the Caldicott Council provides free confidential advice for me and my team as well, where it is needed. There is also ongoing issues with regard to remote working, particularly from other countries. And nationally, there are a couple of things or a couple of countries where they're considered as a red zone, where we can't have any remote working from those areas. However, only in the last couple of months, the NHS England has agreed for NHS Net to be used in some of those countries as well. And if we are asking any of our clinicians to use that, it is done on a case-by-case basis, only when it is extremely needed. So in terms of moving forward, the paper gives some of the tasks, we have put for ourselves. But out of these, I think for me, the key is working with patients and families in terms of updating the leaflets related to confidentiality. And secondly, we continue to be a learning organization, and how we promote this learning through various programs, particularly if there is a breach in confidentiality, which unfortunately does happen every now and then. And then we are also very keen to continue our working relationship with our system partners in terms of sharing confidential information so that the care to the patients is very safe and effective. And also we have a duty to protect our public as well. So these are some of the key points I wanted to highlight. And
Okay.
I'm happy to take any questions. Thank you.
Okay. Thanks, Girish. Okay, I'm not seeing anything, so I think you can take that as approved. Yep.
Thank you.
Thank you. And then Chris Higgins, we're with you next for the green plan, please. And then we're going to take a short break.
Thank you, Chair. So hi, Chris Higgins, I'm Chief Transformation Officer at the Trust. So just here to present the green plan. A couple of bits to note is that this has been through and developed by our Climate Adaptation Group, which is our expert group around environmental impacts and sustainability, and also through the Best Use of Resources Committee, both of which have supported recommendation of approval. So it's here for approval, and it's a requirement that trusts both produce a plan and publish their green plan on their trust website. Just the pertinent points to note is that there's a national target that's set for NHS trusts and around the greener NHS agenda, which is that to reduce to have a net zero position for our direct provision of services by 2040, and an ambition to have an 80% reduction by 28 to 2032. And then there's a further ambition for us to be able to achieve net zero for all our extended services, so our suppliers, what patients have to travel, and all the extended carbon footprint that the trust is responsible for by 2039. So quite a tall ambition, so lots of work to do to achieve that. In previous years, when we've done the green plan, we've probably been a bit overly ambitious, setting out a really expensive capital programme that was probably unrealistic in what we could achieve. So after some discussion through Best Use of Resources Committee, we've gone back and had a re-look at that and taken a different approach. And what the plan now does is sets out what we can realistically achieve with stretch and really challenging ourselves within the resources that we've got currently available. And what you'll see in the plan there's some number of areas of focus. We've already achieved a 47% reduction on our 1920 baseline, which is really good news. However, based on our current resource and estimates, our trajectory means we'll fall short of the 80% target by about 1,500 tonnes of carbon, which you'll see the context of that in the report. So at the minute we're not on track, but that doesn't mean there won't be further opportunities with other investment and other initiatives that we might be able to embrace as over the life course of the plan. Just a bit of context on that. The areas that are proving particularly tricky are our leased properties, so the properties that we don't own, so we can't put the capital investment in to change them like we might do with our own properties, and also what we call our grey fleet, which is our staff cars, people travelling to work and for work in their own transport, which again is a tricky issue that we're trying to work through our options through our leasing arrangements, but again it's a tricky issue. So there is such things as carbon offsetting, so developing green spaces, However, we would aim to reduce our direct carbon emissions as much as we possibly can before we really enter into that world of offsetting. So that's probably as much as I need to talk about. The plans there, and it's here for approval.
Okay, thanks, Chris. I've got a comment and a question from Tim.
Yeah, thanks, Di, and thanks, Chris. So Tim Harry, non-exec director. The comment really is just thanks for a really sort of honest report. You know, you sometimes see other green plans which are very sort of to me ethereal, but this is really down to earth and sets out the challenge. So that's really good, and it's not easy. We know that. My question really is, and it may be something to pick up outside, Chris, but so plastics are very topical at the moment when you consider the global summit that's going on at the moment. And apologies if I missed it, but I couldn't see anything in plastics in the plan.
Well, I'll double back and make sure that that's included. But we do have a plastics agenda in terms of our consumables and disposable. It's been in place for quite a while in the NHS where we're limited on the amount of plastics that we can purchase and use. So we've got alternatives in place, but I'll make sure that's reflected in the plan just to note it. But it's probably because it's been there for a while. It's something that we've not necessarily flagged particularly, but I'll make sure it's covered off.
Great, thanks, Chris.
Okay, thanks, Tim. Good spot. Okay, can colleagues just indicate that they're happy then for the plan to go forward? I'm assuming, Chris, it's going on the website. Is that why it's here for decision? Yeah.
That's right, yeah.
Okay, lovely. Thank you. Okay, thank you. So at this point then I'm going to suggest we take a short break. It's by my clock, it's 23 past. So can we start again at 25 to, colleagues, please? Thank you. Okay, welcome back to this Lincolnshire Partnership Foundation Trust Board of Directors public meeting. If anybody is following this from outside, we're on agenda item 5.5, which is the highlight and exception report from a performance committee. My name's Di Bailey and I'm the deputy chair, and this item is actually against my name as I'm chair of that committee. So just briefly, because I don't want to detract from Mark Platz's thunder around the integrated performance report. Our last meeting on the 31st of July, we did have a conversation at that point about the National Oversight Framework measures not yet being confirmed. Sarah Connery mentioned that earlier in her Chief Executive's report earlier in the meeting. So we await that in terms of further tweaks to our performance measures that we look at. We've heard throughout the meeting around some of the issues with care planning and the weights associated with access to services, which again was one of the areas that we talked about in some detail. And at the other end of the kind of flow process, that we'd continue to have a number of people who are clinically ready for discharge in our services, and the challenges associated with that. On the upside, we noted some real improvement in many of our people metrics, particularly around reduction in agency spend and bank usage and reduction in sickness absence. And that's really all I want to say about the Performance Committee meeting in July, unless anybody has any comments or questions. Okay, I'm not seeing any. So Mark, over to you then with the integrated performance report.
Excellent, thanks Di. So good morning again everyone. I'm Mark Platts, I'm the Chief Finance Officer, and I'm here to present half of the integrated performance report, and at which point I'll hand over to Eve Bird to pick up. So in terms of a kind of overview of the report, just looking at some of the themes before we go into a bit more detail. From a healthy population perspective, some really good efforts around improving palliative care through community and voluntary sector partnerships referenced within the report, and the report also picks up a good assessment around our social return on investment evaluation for some of our community developments as well. So some really positive work around improving our healthy population. From an outstanding quality perspective, I'll start with the good news. So congratulations to those involved for the trust being awarded the Gold Award from the Ministry of Defence Employees Recognition Scheme. So that reflects our drive and commitment to continue to support veterans, which in a community like Lincolnshire is really, really important that we continue to support our heritage and history with armed forces. An area of learning for us that is picked up in the report, and I know is kind of part of other discussions as well, is following a safety inspection by the CQC, Care Quality Commission. Concerns have been raised around the administration of rapid tranquilization across 5 of our wards. A lot of work has gone into to understand more around this and work with the CQC and our services to complete both an initial rapid action plan. So really important to resolve any immediate issues that we can do as soon as we can, but more importantly, get a developed sustainable action plan in place so that we can really embed and sustain those improvements in our processes moving forward, so we can learn from that. So big thank you for the teams that have supported the development around that, and we're continuing to work on those plans and implement. We'll also note some great work by our dementia services. So our 18-week wait breaches have reduced by almost 10%. So whilst they're not where we want to be, we have seen that fall in breaches of our waits. So we're down to 26% of our patients kind of breaching that waiting list target as well. So some really great work moving forward on that. From an outstanding people perspective, continued reduction in vacancy rates. So for us this month, reporting on the data, so we're just at 8.8%, 8.79%. And sickness absence is also low as well at just over 5%, 5.1%. Now, there's been some really good targeted work around supporting absences in our high absence areas, and some really good teams are noticing some really sort of lower rates of sickness absence at the minute, which is really positive to see. However, an important point for us to note is the continued anxiety, stress and depression accounting for almost 41% of all our absences. So really important that we keep digging on that. And I know the people committee and the people team are working hard to understand more around that, how we can support our staff. Which brings me on to two final things for outstanding people. Staff wellbeing. Really important that we can support our staff through the turbulent times at the minute as we go through a couple of programs which I'll mention in a second. Our employee assistant program, so this has now gone live. It is an externally provided system that does provide confidential support around any personal or professional matters, and I've used the service personally, and it's good, high quality service, so good to get that embedded within the trust. From a staff safety hub perspective, I know I've mentioned this previously within previous reports. This is being implemented now as part of our support services redesign work. So from that perspective, we're going to have a very clear process where staff can escalate concerns around safety, and we can enact an action to resolve them. From a best use of resources perspective, I am conscious that this is our first report where we're looking at the current financial year's data, because the last report when we met previously was looking at the financial year end for last year. So I'm just going to do a bit more information around this one just to set the scene for those that are watching. So for this financial year, the trust has planned a deficit this year, so it's the first deficit for a number of years, but we're working hard to try and rectify that. So in terms of numbers, we have planned a deficit for the year at £3.7 million, and our current position on that is just shy of £830,000 deficit in year, which is slightly off our phased plan for this year. However, there's significant amounts of work that's being done to make sure that our saving plans both this year and the future are delivered and sustainable. So we mentioned at our last meeting around the Living Within Our Means programme. This is fully embedded now, and a number of work streams such as our support services redesign are really starting to move forward and helping us to understand our staffing models and service designs of the future to make sure that we can deliver the best care that we can with the resources that we have got. And I did just want to highlight as well on the back of this, a big thank you for everyone that's been supporting us around our use of temporary staffing. So I have mentioned in previous reports, temporary staffing can kind of often influence and impact stability on wards and kind of working through that. So some really great work around getting us stabilised across our wards and recruiting to substantive members of staff, particularly around our medical consultant. So a lot of medical consultants have joined the organisation, which is helping us to not only provide better care, but actually also spend less on external agency support. So we're already spending over £300,000 less on agency than we'd planned to at the start of the year. So some great work done there by our colleagues. I'm going to hand over to Eve Bird, if that's okay now, just to talk through some of the performance highlights included in the report.
Thanks, Mark.
Thank you, Mark. Good morning, Eve Bird, Chief Operating Officer. So picking up where Mark left off, I'm going to share some of the performance highlights and also the performance challenges described in the integrated performance report. So in terms of some highlights, we're doing well with our talking therapies reliable recovery rate, so 50.4% against a target of 48%. Our children and young people's access rate for the first time in a long time above target, 103.8% achievement. So that's really positive and shows a lot of the outputs, really, the outcome of the work that we've been doing to make sure that we're recording all across all the services that we have in the system in Lincolnshire that children and young people might access, that we're recording those contacts accurately and feeding that information through so that we've got a genuine picture of how many children and young people are accessing support for their emotional well-being or their mental health. Follow up within 72 hours of discharge, we're at 91.4% against a target of 80%. So that's really positive. And you know, anybody who has used inpatient services will understand the importance of having timely follow-up to check in and make sure that during that time post-discharge things are going okay and there isn't extra support that we need to put in. The other highlight I wanted to flag is in terms of our data quality maturity index. So we're within the top 10% of providers for that. That's really positive, because what that tells us is we can be confident in the quality of the data and the accuracy of the data we're reporting. There are some challenges though in performance, and we've Di mentioned earlier, we've been talking a lot about our performance around waiting times. So within the integrated performance report, we're reporting on an ambition, a community mental health ambition for individuals to be seen within 4 weeks, and the performance we're reporting is really quite low on that. Nationally, this target is currently in shadow or test form for NHSE, and what they've done is given a very specific definition of what stops the clock. So that's what that data is reporting really, and that stop the clock happens when somebody's had an appointment, when there's a completed outcome measure recorded on that person's records, and when it's also recorded within that person's record that a specific intervention that's coded in a certain way has taken place. So we've got to get all of that right because we're reporting on it nationally. But what we're doing in the background is also monitoring waits that are completed from a patient's perspective. So when someone is seen and they've started to receive support, at that point, from a patient perspective, they're no longer waiting. And what we see within our community adult mental health services is that we're achieving that within 4 weeks for about 61% of the people who are referred into our services. So that's really good and really positive. Still more work for us to do so that we're achieving 4 weeks or less for everybody, but a lot better performance than we're seeing against the standardized way of recording it. And our average wait within CMHTs at the moment is about 5.2 weeks. So really close to that 4-week wait. And a lot better than the 12 and 18 weeks that we've been measured on previously. So we're seeing good progress with waits, but there is still work for us to do. And the same applies to our children and young people's waits. We've also got some challenges around autism diagnosis and the waiting list. And we're seeing an increase after doing a lot of targeted work and seeing a real decrease in waiting times and number of people waiting for prolonged periods of time. We are seeing an increase now in the number of individuals waiting over 52 weeks. This is because the demand for that service is growing continuously and hasn't stabilized as we hoped it might and predicted it might when we were looking at predicting future performance. So we are monitoring that demand. We're talking with commissioners about the capacity we've got compared to the demand, and we're also reviewing our pathways to make sure that they're as efficient as possible and that we're completing as many assessments as we can. What I do want to offer is some assurance that we do prioritise according to risk or impact on an individual. So we do have some people waiting a very long time, but if it's assessed that someone's assessment will significantly impact on their ability to maintain education or employment, or their ability to continue to function in their community, we are prioritising those individuals and seeing them as quickly as possible. So I just want to offer some support around that. And the other area that I wanted to highlight in terms of challenges is the number of people we've got clinically ready for discharge who are currently still on our wards. And we're doing a lot of work across the NHS and the local authority to agree what actions we can take to make sure that people are only staying on our wards for as long as the treatment is adding something to their recovery. For example, exploring things like step-down housing accommodation and re-enablement offers and enablement offers. So we are doing a lot of work in that space. Finally, I just wanted to mention patient experience and outcome measures that are also included in the integrated performance report. We've got 92% of patients rating their experience or good or very good, which is absolutely brilliant. However, we're also doing some work to understand how many patients that access our services we're then hearing from in that context, because the more patients we're hearing from, the more confident we can be in whether that is the experience for the majority of patients. In a similar vein, we've had 87% feeding back that they feel involved in care decisions, and that's been a really important target for us. We want to work with people, and we want our offer to be led by the individuals who are accessing our services. So that 81% feels like a really good figure and a really good indicator, but we do need to hear from more people. And then finally, I just wanted to highlight some of the amazing work our patient partners are doing. They're doing so many projects, I could speak for hours on it, but things like working to develop ward round standards and admission leaflets on our wards are having a real positive impact on the way we're delivering care and the way we're supporting people here and now. So that's a brilliant initiative. And that's it from me, Mark and Di. Thank you.
Thanks, Eva. Really high note to end on there, I think, and thanks to our patient partners for all that really valuable work that they're doing. I think it's fantastic. Okay, I think you've been very comprehensive, because I'm not seeing anything in the chat that anybody wants to comment or raise a question. So thank you, and we can move on to gosh, here we are sitting in the middle of August in a heat wave, and Chris, you're going to tell us about the winter plan.
Indeed, thank you, Di. Yeah, so Chris Higgins, Chief Transformation Officer. So again, a national requirement for all trusts and integrated care boards is to develop a plan ahead of winter to make sure that we've got the right capacity and capability in place, and actions to make sure that winter is as smooth as it can be from a patient delivery, care delivery perspective. What helpfully NHS England have done this year is set out a checklist for winter plans, and you'll see from the report that that's how we've structured the report around those specific areas that are questions and challenges for us to consider what we're doing about that as an organisation. They're broken down to areas of prevention, which is predominantly around flu vaccinations and the like. Capacity issues, infection control in its broader sense, leadership, and some specific actions for mental health trust. You'll see from the report that we're satisfied that we're compliant with every area that's relevant to us as a mental health and then disability and autism provider. And then at the end of the report is an assurance statement that boards are required to make. And again, what we're suggesting here, subject to board's approval today, is that we can give positive assurance against each element of that's relevant to LPFT. So it is here for decision and approval of the board assurance statement, and then we'll be required to submit. The only thing just to add on that is that just because of timeframes of meetings and making best use of people's times, there is an exercise that we will have to be represented at the end in September, that's supposed to stress test winter plans across organisations and regions, and we've got a regional event that's lined up with members of LPFT and the ICB to attend. We're supposed to wait until after the event to be able to then submit our assurance statement. But what I'm suggesting, because of best use of time really, is that we approve it today subject to that. As long as we attend and appropriately represented, and that there's nothing that comes out that's of import, then we'll be able to proceed with the submission. So since they're happy to take any questions though, but hopefully it's relatively self-explanatory.
Thanks, Chris. And just in case there was anything that came out of that regional event, presumably we'd get some sort of recirculation virtually, I'm assuming.
Yeah, that's right. If there's anything significant that came out, I'd definitely recirculate it for further approval. But yeah, otherwise we can go through that. I'm not expecting that. I think it's just a stress test. I'm not expecting anything to come out, but yeah, absolutely.
Fine. Okay, thank you for that. I think people are happy to approve. Yep. Thank you. So we move then into the section of the agenda around healthy population, although we haven't got anything substantive under that, although I think there have been references to healthy population throughout the meeting so far. Over then to regulatory issues, and Ian, highlight an exception report from the last Audit and Risk Committee, please.
Yeah, thanks, Chair. Ian Orrell, Chair of the Audit Committee. I think I can be really quick on this. I think the report itself is fairly clear in terms of the issues that we've been involved in. Couple of things I just wanted to mention, and in a sense they've been mentioned throughout the morning session, and that is the first of all the areas around improving our risk management and the BAF in particular, and we've heard this morning lots of examples of that, and the Audit Committee will continue to seek to see the appropriate level of assurance and progression with our risk management processes. And then the other thing that I mentioned in the report is that we are, of course, cited and want to continue to be cited on the issues around the CQC inspection and also the Living Within Our Means initiative. So other than that, don't think there's much to say unless there are any questions people have. Thank you.
Thanks, Ian. Not seeing anything, so I think you're done. So Karen, fit and proper person test, please.
Thank you, Di. So this is here for the Board of Directors information, and predominantly about providing assurance to members of the Trust and the wider public that in line with NHS England's fit and proper person test framework, all of our current board members remain compliant with the requirements of that framework. It sets out within the paper, I hope, fairly comprehensively about changes that have taken place within the reporting year within the board, some new appointments and also some reappointments. And additionally, whilst those checks for those individuals have been the full set of checks, for other directors that have remained in substantive positions, there are a number of annual checks that have to be carried out. So really here for information, as I say, Di, but happy to take any questions.
Okay, I'm not seeing anything, Karen. I think it's self-explanatory actually, so thank you. So the next one is with us for decision. This is the review of board committee membership in terms of reference, is that right?
It is, Di, thank you. So this is the board's annual review of its committee membership and various committee terms of reference. As you would expect, each of the board committee terms of reference have been reviewed by their respective committees in the most recent round of committee meetings. Any amended highlights or proposed amendments are highlighted within each of the documents presented. So I'll take it as read. Happy to take any specific questions or comments though. Thank you, Di.
Yeah, and I thought it was a self-explanatory document, so I'm not surprised that I'm not seeing anything, Karen. I think that's fine. We're happy. So we're staying with you for the forthcoming board programme. These are items to note.
Yeah, nothing specific to highlight other than that that's listed within the document, Di. Obviously, anything that crops up in between board meetings, we do obviously make board members aware of as and when they occur. Thank you.
Okay, thank you. Thank you. So then the final item, Chris Higgins, is with you. This is a review of our emergency preparedness, resilience and response and business continuity policy. Goodness me.
Yeah, thank you, Di. I'm not intending to go into detail on this one. It's been through our Health and Safety Committee, and our subject matter experts around emergency planning have been involved in the production of this. It follows the national guidance around the policy and what requirements were required, and picks up issues and actions that were identified in last year's national self-assessment around emergency planning. It's been through the appropriate governance, including the best use of resources committee, the policy and practice group now for approval. Yeah. So it's been through the appropriate mechanisms, and it's just here for final approval before uploading.
Okay. Again, I'm not seeing anything. I think it was fairly self-explanatory, so thank you. That's fine. So I've not been notified of any other business. I think it's been a full agenda, but it feels like we've done justice to the number of annual reports that we've had in front of us and other updates as we've gone through. So thank you, colleagues. I advocate that we close this meeting now, and then we commence with the private board follow on. We'll do that, and then obviously take a break depending on where we get to with the agenda in private board. So thank you, everybody. See you shortly.
Thank you, Di.